Our next speaker is Dr. Robyn Clark. Professor Robyn Clark is a senior clinician and mid-career researcher. She holds qualifications as a registered nurse, registered midwife and critical care nurse, a master's degree in education and a PhD. Professor Clark is currently a Heart Foundation Future Leader Fellow, a Fellow of the Royal College of Nursing, Fellow of the American Heart Association and Life Member of the Australian College of Critical Care Nurses. Professor Clark was the inaugural recipient of a National Institute of Clinical Studies PhD scholarship supported by the National Heart Foundation for researching telemonitored heart failure management in rural and remote Australia. She completed an NHMRC Australian Training Fellowship at the Queensland University of Technology in 2013, after which she commenced her appointment at Flinders University as a Professor of Acute Care and Cardiovascular Research. Professor Clark currently holds adjunct appointments at the University of South Australia, Queensland University of Technology and the South Australian Health and Medical Research Institute. Professor Robyn Clark is internationally recognised for her research into the most effective management of patients with heart failure and cardiovascular disease. Professor Clark's research program can be summarised under the overall theme of increasing access to evidence-based care for underserviced and disadvantaged populations. Please join me in welcoming Dr. Clark.
I've only got 10 minutes left after that introduction, so I'll make it quick. Mechanics in ACS is the title I was given to present today. And in my disclosures, I'd like to acknowledge my funding and my Future Leader Fellowship. It's also always important to acknowledge your sponsor, but I also need to disclose that when it comes to mechanics, I think I'm probably more like a Tesla than a Tirana. And interestingly enough, when I put Tirana into the slide, Google didn't recognise the word. So that's probably a sign of age there. And so less Charlene and a little bit more Abby for this presentation. So in 2017, the Stemi Guidelines from ESC were released with this wonderful schema on ischemic time in ACS. And as you can see, a total ischemic time represented in this schema includes patient delay, EMS delay, and then system delay. And as we know, total ischemic time or ischemic time in ACS is generally still measured door-to-needle time. So in this presentation, I'd like to argue that door-to-needle or door-to-balloon time is quite an illogical measure of ischemic time, especially when a patient's been waiting 24 hours to 3 days. And the current Australian ischemic time has reduced from 6 hours to 3 hours, but still a long way off reaching a 90-minute target from onset of symptoms to reperfusion. So I really want to argue that ACS should be looking at total ischemic time always, and that we need to think outside of the box, outside of the hospital, in all of our strategies for improving outcomes for ACS. And they will, in today's talk, I'm going to talk about bringing patients to the hospital quicker, bringing the hospital to the patient quicker, continue to improve door-to-needle and balloon processes and the late-breaking trials from this year in that area. And finally, I'd like to show you, there's a bit of overlap in our talks, a glimpse of the future, which I think would be particularly interesting for intensive care. So this is my schema, which shows what affects ACS. The ischemic time is the delay time of the patient, the arrival of the EMS, and then the EMS to the hospital. And we have an additional issue in South Australia at the moment, which is ambulances not even getting through the door these days, hospital time. And then also I'm going to talk about important aspects of discharge and then the future of hospital at home. So as we know, the maximum benefit of ACS treatment is in 60 minutes from symptom onset. This was described about 20 years ago by Boersma, and it was called the cardiac golden hour, and it's in sync with the trauma golden hour, and the outcomes are quite clear that if you get to hospital quickly, you will have better outcomes. So the current ACS KPI is 90 minutes door-to-needle balloon time, as per the schema I just showed you. But significant gains have been made in pre-hospital care, so there's a lot going on in the back of the ambulance, and there's a lot of new initiatives inside the hospital, which we'll talk about. And I also wish to acknowledge the work of AUSROC, which is some close colleagues of mine in ICU origins, who have been bringing together data to give us statistics on what our current performance is. And as previously mentioned, if delay leads, so if you wait too long in your out-of-hospital chest pain, obviously, and it leads to cardiac arrest, then mortality is 90%. So it's not a good idea to wait too long. And pre-hospital delay times have changed little over the last 10 years, which is pretty disappointing. It's actually disappointing there's not a lot more work in this area. So 60% of patients discharged after ACS will experience some angina, which is quite high. It's how they deal with it, which is important. And 20 to 41% will have angina within 30 days of discharge, and I'll talk about the importance of that later on. Survival to hospital discharge with an out-of-hospital cardiac arrest ranges from 6 to 13%, and that's AUSROC data from Janet, who's here in the front row in the audience today. And patients, interestingly enough, patients with previous cardiac events who go home continue to delay. They're not actually better at responding to their heart attack symptoms when they go home, and they continue to attribute these symptoms to other things. So what are the solutions for getting the patient to the hospital quicker? Well, solution one from the Heart Foundation was a mass media campaign in 2013, and then 3 months after that, a survey of patients was conducted to look at the outcomes or the impact of that mass media campaign. And there was positive outcomes from that survey. I don't know if you remember, I wish I had my heart attack again. And it did, patients who saw the media campaign, who had a history of cardiac events, did reduce their delay time in presenting to hospitals, so that was significant. One of the myths at the time from physicians, particularly in ED, was that there would be a tsunami of people presenting to EDs, and this definitely did not happen. However, these mass media campaigns are expensive, so you notice we haven't had too many of those since 2013. And of course, the sustained results of these media campaigns is yet unknown. So another solution that my group has been working on is standardised bedside education for recognising heart attack symptoms and responding appropriately. So meet Cora. Oops.
Hello, my name is Cora and I'm a nurse. I've been looking after people with heart conditions for a long time. At any time, you can tap on the menu button in the top left-hand corner to go to a specific section. It is important to understand that warning signs can vary from person to person. Tap on the pictures for more details. Discomfort or pain in your jaw. People who have experienced discomfort during their heart attack describe it as an ache or a tightness in and around the lower jaw. You may also experience other signs and symptoms.
So this is just a flyover.
You may feel dizzy or lightheaded while experiencing other heart attack symptoms.
It's not a lecture on an iPad. The avatar, as you can see, engages the patient, and there's expectation of interaction with the avatar, with the Q&A and the quizzes. And it goes through a series of teach questions again. So we go through all of the symptoms, then we go through a quiz, and then we go through a response and actions. So Nurse Cora and this avatar teaching app for teaching is a world first, and she is word perfect from the guidelines to teach patients the emergency action plan at discharge, and they can download it and take it home. Very few nurses can deliver a word-perfect, guideline-based bedside education on the action plan. The mean time for completion of a session is 8 minutes, but we're working on a 3-minute version. And that's because psychology researchers told us that it's about the standard attention span of a human at the moment. 3 minutes is the length of a song, and you can tell a whole story in a song. Boy meets girl, boy loses girl, chorus, chorus, la la la, and then back together, happy ending. Symptom images are based on science, so we looked at the symptom epidemiology, and if the symptom is most common in the male sex, then it's a photo of a male person having that symptom, and vice versa for the more common symptoms in females. We used web-based design for elders. There is quite a big amount of science in that, so clean backgrounds, large fonts, certain colours are not recommended for, and you can see the red that I use in the header here, it's slightly maroon, which is easier for old rods and cones to pick up in 70-year-olds. Nurse Cora is deliberately made to look international with dark hair and dark eyes and skins, and she can be programmed by the computer to speak 144 languages. We can easily adapt her to other healthcare systems, so she can talk about 911 or 000 or 999, whatever country she's in. And we've completed a powered RCT just recently, not so funded, but we did show significant improvements in knowledge and action of the patients involved. So we've applied for an international grant, and Janet and I have joined forces for this. And we're hoping a positive outcome this year, where we will test Cora in 4 countries in 7 hospital sites. So what about bringing the hospital to the patient more quickly? So as you know, or may not know, Micah, the intensive care ambulance, celebrated its 45th birthday just recently. And just recently as well, a new mobile stroke ambulance has been tested in Melbourne. The mobile stroke ambulance has an intensive care paramedic, a CT radiographer, a stroke neurologist, and a stroke nurse specialist in this little itsy-bitsy cute CT scanner in the back there. A trial was commenced in November 17, and so far 400 patients have used the ambulance, and they're reporting a 50% reduction in door-to-treatment time. So we look forward to the final outcomes of that. So in comparison, there's a new thing on the scene, which is sonothrombolysis. I don't know if anyone's heard about this, but this will be significantly important for the 7 million Australians who are outside the 90 minutes from PCI. And the hypothesis for sonothrombolysis is that the term they use is microcavitations, basically little holes. And there are small holes in a thrombus, and ultrasound contrast is small enough to go into those holes. And then when you put the ultrasound onto the thrombus, the ultrasonic sound waves makes those small holes larger, and more TPA can enter the thrombus. That's the Robyn physiology version of this. So this sonothrombolysis is now in phase 3 trials, and there hopefully will be some trials in Australia. Ultrasound is well established in the back of the ambulance, so this is the perfect place in Australia to implement this new treatment for ACS. And obviously we can add TPA and ultrasound to MICA support, so stay tuned to that one. So what's happening inside the hospital? Well, this terrific slide was prepared by it's not very clear, sorry, by a statistician after the ACC late-breaking trial. So this is a summary of late-breaking trials. The Odyssey trial was a study of etrusumab versus placebo in acute coronary syndrome, and there was a fantastic positive outcome for using that in ACS. So the statistician has made comments at the end, a caution that the post-hoc subgroup analysis was not powered, but it's not significant for this. VEST was studied also in late-breaking trials, and it showed that a wearable cardio-converted defibrillator had no significant reductions in sudden cardiac death. The secure PCI, which was atorvastatin loading dose in ACS patients having PCI had no significant reduction on MACE. The TREAT trial, which was tratacolor versus clopidogrel, had no significant differences. And POSE, which is metoprolol versus placebo, also had poor outcomes, actually, and it was considered that the metoprolol dose was too high. The SMART date trial, which was 6 months of dual antiplatelet therapy versus 12 months, showed no significant differences in MACE. And the CVD REAL trial, which was sodium glucose comparator 2 for type 2 diabetes, did lower event rates and death in heart failure, myocardial infarction and stroke, but it was only an observational trial. So just a quick summary of what's happening, late-breaking trials in ACS presented at ACC. At ESC a couple of weeks ago when we were up there, late-breaking trials for ACS, the most interesting trials were this high-stakes one, which was a comparison of high-sensitive troponin versus standard troponin testing. And there is currently an NHMRC trial on this in Australia. The outcomes of this study showed that patients reclassified using high-sensitivity troponin after a negative result with contemporary troponin were just as likely to suffer a consequent MI or die from CVD at 1 year. Rates of PCI did not increase with high sensitivity in troponin. More patients underwent coronary angiogram. Unfortunately, hospital stay increased 30 hours with this high sensitivity test, and it's actually meant to reduce it. So currently it's a 6-hour standard test, so that was the surprising result. And the high sensitivity assay was effective in identifying patients with myocardial injury, but very poor for myocardial infarction. Another trial that was really interesting at ESC was MATRIX, which was a comparison of femoral versus radial and a bolus dose of bilirubin. So the outcomes, there were 8,000 patients, there were 78 hospitals in 3 countries in Europe, so very high-powered study. The outcomes were that it was really a non-inferiority outcome, so there wasn't any worse outcomes with radial access versus femoral. Unfortunately, the bolus was not significant, so the conclusions were that it's still controversy over the optimal antithrombic regime to use during PCI. However, with the non-inferiority results of radial access, it probably should become the default approach for invasive management of patients with ACS, which is a good outcome. So now look at in the hospital, but more significantly, bedside teaching. So unfortunately, we're in an environment where we have extraordinary lengths of reduced lengths of stay. This is a good thing, and I think PCI will be a same-day procedure very soon. Also, we're seeing this changing roles of nurses and specialisation, and skills and confidence of new bedside nurses is variable. That's a nice way to say it. 75% of patients in Australia and New Zealand have reported that they are being discharged from hospital without receiving basic follow-up advice and prevention and care. That's particularly so for emergency action plans. We've also done a big linked data analysis recently in South Australia and found that this bedside education moment might be our only chance to give information to patients to prevent readmission, because 70% of patients who were referred to cardiac rehab didn't show up. So that's it. We don't see them again. And it really is our only opportunity to educate. For those people who did show up in the 30%, they actually did show a reduction in hospitalisations of 14%. And unfortunately, the 70% who don't show up to cardiac rehab come from low socioeconomic areas, so they're probably the most in need. Another study has shown that patients who do not attend cardiac rehab or outpatients in particular are twice as likely to be admitted in the next 12 months. So it is a significant issue. Not only that, but in the US, they are now penalising people for 30-day readmissions. And this slide just tells you the list, the top 6 lists of DRGs that they're focusing on this hospital readmission reduction program. And so it makes hospital discharge and discharge planning even more important. And this formula, blah, 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 basically it shows that if you have 5 times more readmissions, you are penalised 5 times more in the reduction of funding to your hospital. So it's significant, and it's really put, I was going to say a bomb up, which would be a more scientific way to say it. It's really motivated people, particularly in cardiology, to focus on discharge planning and discharge education and hospital prevention, and particularly 30-day readmissions. So we thought, okay, well, what is the evidence for discharge education, and how do you do it? What's the most effective way? Well, that was a pretty disappointing exercise in this systematic review. We found a study for 175 patients. We found 3 studies, 2 from New Zealand and 1 from Switzerland. One of the studies was an interesting psychological intervention, and the other 2 were education prior to discharge. They showed positive outcomes on knowledge and medication adherence, but not one of the 3 studies measured the effect on readmission. So basically, in 60 years of acute coronary syndrome practice, we have 2 small RCTs and 1 pilot study on discharge education and training. So unfortunately, we have a huge practice gap in Australia as far as what we're doing at the bedside at the end of a cardiac event stay. And I really question what is going on in current practice. So must be, I don't know, what evidence are they using for discharge education and discharge planning? So that's really just a question mark slide. So in the secondary prevention area, the study that has really rocked the cardiac world, I know there was a lot of scuttlebutt at the Heart Failure Society of America meeting last week, which was a huge study over 7 years. I think it was from Monash. Yes, it's from Monash. 19,000 participants in Australia and the US, 100 milligrams of low-dose aspirin a day. They weren't to have any cardiac or stroke events, but did an aspirin a day keep the doctor away? And the answer is no. It did not prolong life. It did not prolong life free of disability or significantly reduce the risk of first heart attack or stroke. So very interesting outcomes from the aspirin study. So don't do that. Don't pop an aspirin just because you think it will be prophylactic. And another bomb that went off in the UK in 2012 but has ongoing consequences for secondary prevention was the RAMET study, and I don't know if you've heard of that, but in the UK they did a large trial of 178 cardiac rehab programs across the UK and Wales, and found that going to rehab had absolutely no impact on mortality at 2 years. And in fact, at 2 years, patients who'd been to rehab were actually doing less physical activity. So the recommendations from this was that we need a whole revamp of not the evidence, because the evidence for lifestyle changes is strong, but how the lifestyle changes intervention is delivered, the modes of delivery is in the current system is not working. So the UK has done major reform in improving the quality and outcomes for cardiac rehab programs, and there's been reports annually from 15, 16, 17 and this year to show those improvements. But unfortunately in Australia, the response to this has been slow. There hasn't been a similar study done in Australia, but we could definitely generalise the results of this, and it really is time for disruptive innovation on how we deliver cardiac rehab. So finally, good timing, I want to show you my version of the future, which is hospital at home. And again, a little bit more Tesla than Tirana this time. What we have here is a video of EMMR, Enhanced Medical Mixed Reality. And I have to confess that I had a dream that I always wanted to be Princess Leia, for many reasons, but one of them was I could see that when she did the 3D hologram to deliver messages through R2-D2 to Hans, that you could actually do that in people's homes. You could have a 3D hologram of a nurse come to people's home, patient education and interaction, and that would be really cool. Well, it's for real now, and this is quite incredible. And I see EMMR being fantastic, not only for ACS, if you're in the middle of chest pain and you don't know what it is, but for sure for heart failure, because critical care at home for heart failure is a new innovation it's particularly been trialled in Sweden. Definitely for transplant, and particularly for country transplant patients who have to drive miles for specialist care quite often. And obviously ICU at home, which has been talked about for many years, but has tried and failed, and obviously funding is an issue. So have a look at this and see the future, but actually I'm telling you, this is in practice.
At Silverchain, our vision is to deliver the world's best health and aged
Christopher
care in
McGowan is
people's
now
homes
head
so
of
they can live
South
their
Australian
whole lives as
Department of
they
Health,
choose.
so we're lucky to have
We
him.
know that Australia's demand for healthcare is increasing, partly because of an ageing population, but also because of the increased number of things we can do in hospitals. And our research shows that about 30% of people in Australian public hospitals today don't need to be there. And we know we can deliver them really high quality care at home. Now this will not only increase the safety, increase the convenience and be what people prefer, but it will relieve the pressure on our public hospital system.
So the nurse comes on, puts on the
people
glasses.
who really do need that level of care. Our new technologies allow nurses who are on a day-to-day basis responding to clients in their home to be able to have really good access to the data, be able to have their hands free while they're reading data, but also importantly consult with a doctor and have the doctor see what the nurse is seeing and the data at the same time as giving the nurse advice about how to treat the patients. This significantly increases the capacity of the nurse to practice at the top of her profession, and it gives the doctors an incredibly efficient way of being in many places at once. Enhanced Medical Mixed Reality, or EMO as we call it, creates a hologram of a doctor, so the experience is a doctor's really personally in your home, talking to you, in dialogue with you, looking at you, and consulting with you about your healthcare. So the experience is a doctor has come to your home and visited you. We think this is going to meet the demand for increasing healthcare for our community in a way that's not only less expensive, but is much closer to what people want and takes the pressure off our hospitals for the future. It's part of our vision for a new generation of healthcare for Australia, and it's coming soon.
That is so cool. So, in summary, I focused on strategies to reduce total ischemic time and ED process time, and I put dollar signs next to the items that I think will really be cost-effective measures in the future. We have to look at increasing the efficacy of revascularization and the efficacy of our pharmacotherapy, and you can see from the late-breaking trials that there's a lot going on there. Not always working, but always new drug trials happening. We have a lot to do in the secondary prevention space, and definitely reducing length of stay and reducing readmission could be achieved by some of the new strategies like EMMR. Thank you very much.
Thank you, Robyn. Does anybody have any questions for Professor Clark?
Thank you, Robyn. I have one, just while people are thinking of questions. With the avatar, is that personalised to the patient? So if they're an elderly patient or a female or people who may have atypical symptoms?
So that is a great question, actually. We have another group of avatars for heart failure. So in this one, we thought the emergency action plan probably should be delivered by a nurse because it's a little bit more serious. We're working on a male nurse, but in this one, no, the avatar's not personalised like you do in gaming, and we're using gamers to design. In the heart failure one, instead of the nurse delivering the education, it's peer teaching. So it's a man like you or a woman like you who has heart failure like you. And at the beginning of the app, at the beginning of the avatar, you can put weight on them, you can change the colour of their hair, they've actually put these glasses that I wear all the time into the app, so you can, put Robyn's glasses in there. We've added quite a few skin colour. You can change skin colour. And so, yes, that adaptation and personalisation is in our next app for heart failure. And that is how a lot of games start anyway. So we thought it's an important process for engagement and to get the patient having fun at the beginning. We work with the gamers, and the gaming IT developers have a school teacher with them. And we get a lot of really good advice on patient education from the school teacher. And the first thing he told us when he saw the emergency action plan was, it's pretty serious, isn't it? And we're there, oh yes, emergency action plan is that's my nursey voice, is a very serious matter. He goes, but for learning, there should be a little bit of fun. And you notice that Cora is she's not that deadly serious with a deep voice. She's the kind of nurse you would want at the bedside. She's engaging, and she does funny things, like if you don't respond in time, she stands there with her hands on her hips and she waves and she's like, are you there? So there's a little bit of, not frivolity, but it's not totally deadly serious, because we didn't want to cross that line to be so serious that it was sad and not engaging. So that's a good question, and we've done that in our second act because we've learnt from this one.
Fantastic.
Well, if there's no more questions, thank you, Dr. Clark.
Thank you.